Steve Treon. I'm a professor of medicine at the Dana-Farber Cancer Institute and Harvard Medical School, and the director of the Bing Center for Waldenstrom's Macroglobulinemia. I'm also the scientific co-chair at the International Waldenstrom's Macroglobulinemia Foundation. Today, I'll be providing a timely update in the treatment of Waldenstrom's macroglobulinemia. These are my disclosures. Please note both my disclosures for research support, consulting, and honoraria received from various biopharmaceutical companies, as well as intellectual property. But also note that I'll be talking about investigational agents today, including Venetoclax, Pirtobrutinib, Ulocuplumab, as well as Mavorixafor. Now, I think a very proud moment in our foundation's history was the support for whole genome sequencing. And what I have to really talk about for the rest of the day today actually emanates from this important discovery that was made possible through whole genome sequencing. This work, of course, occurred in my laboratory at the Dana-Farber Cancer Institute. It was funded by the IWMF as well as by Dr. Peter Bing. And it was actually introducing whole genome sequencing at a time that this was actually a new art for being able to discover mutations in cancers. And so when this all started, we were there among the pioneers using whole genome sequencing. And what did we learn from this study? Well, we learned that over 90% of patients with Waldenstrom actually had this mutation in the MYD88 gene. I'm going to talk about this quite a bit in just a moment. Now, important because of this discovery was that we could use MYD88 as a diagnostic tool in terms of working up patients who were suspected of having Waldenstrom's. But also, more importantly, it gave us really an incredible glimpse into how the Waldenstrom cells grew and survived. And essential to these discoveries was, in fact, the support of the IWMF as well as Dr. Peter Bing, but also this very, very bright scientist in my laboratory, Dr. Guang Yang. And he began to decipher what the MYD88 mutation actually did. And so, not to make things too complicated, it's important to recognize that MYD88 is part of a alarm system that triggers, a cell to respond if, in fact, a virus or bacteria is encountered. And there are these receptors or antennas that exist on the cell surface of immune cells that actually cause this MYD88 molecule to be turned on. Well, if you have the mutation in this molecule, you no longer need this on switch. This actually is turned on, and it's turned on permanently. But what it does actually is very interesting. It's like a big octopus, because whenever you sound a fire alarm, of course, you're going to get a big response. And that's what's happening here, which is why these cells are growing and surviving. And all these very elaborate circuits have been, in fact, worked out largely through the work of Dr. Guang Yang in our laboratory. But what you see here as part of this very essential pathway is that you have this molecule called HCK being turned on. And in turn, HCK turns on BTK, which is, as many of you know, the target of drugs like Ibrutinib, as well as Zanabrutinib and other BTK inhibitors that I'm going to talk to you a bit about in just a moment. So as a result, you've got this pathway that's turned on because of MYD88 that's driving growth and survival signaling. But you also see, as you decipher these signaling pathways, as you learn about these circuits, you also see all the drug opportunities that now exist to us. And we'll be able to talk about a few of them today. So the other important mutation, I know many of you already know about this, is CXCR4. We see this in about 40% of all Waldenstrom patients. This too was also discovered in my laboratory thanks to whole genome sequencing by Dr. Zachary Hunter. In fact, it was after the discovery of the MYD88 mutation that his further prowess in investigating the whole genome of Waldenstrom that he actually discovered these mutations. And these are kind of interesting mutations. This actually is a receptor. It's also an antenna that sits on top of the cell, the Waldenstrom cell, and it binds actually to this protein called CXCL12 that's actually made by the bone marrow. And in response to CXCL12, a lot of things happen to the cell. Most importantly, you get trafficking of the cells to the bone marrow, but you also have very elaborate, signaling that supports the growth and survival of the Waldenstrom cell. And it also tends to make the cell resistant against certain types of drugs like the BTK inhibitors. So Zachary actually made some interesting discoveries. He found over 40 different types of mutations in CXCR4, along with other colleagues, I should say. And the classes of these mutations come in two different flavors. Those that we call nonsense, where you actually put a mutation in that cleaves off part of this tail of CXCR4, or those that we call frame shift, where you introduce DNA or take out DNA and you scramble this code. The ones that are nonsense actually tend to be the more virulent ones, and we'll have maybe an opportunity at the upcoming forum to talk more about these. These also tend to be the mutations that tend to be more resistant to BTK inhibitors. Now, the first trial, as I think all of you know, with a BTK inhibitor in Waldenstrom's was that of ibrutinib. This was a trial that I had the privilege of being the principal investigator. It was first published in the New England Journal of Medicine back in 2015, and we just had an update of these results in the Journal of Clinical Oncology this year. Now, what do we learn in this study? Well, we had a very long follow-up, and we learned a couple of things. One, we got great results, considering that these were heavily pretreated patients, and 40% of the patients were refractory, meaning they didn't respond to their previous therapy. So in fact, you see here overall responses in 90% of patients, major response in up to 80%, where you saw at least the IgM go down by 50%. And even VGPR, which means 90% reduction in disease burden, occurred in about 30% of patients. But if you look at the MYD88 and CXCR4 mutation status, these responses differed. The patients that only had the MYD88 mutation did the best. They had, in fact, up to half of them had a very good partial response. If you had both mutations, you see that the major response rate went down by a little bit, but still down. But look at the very good partial response. You see the big difference. With the introduction of CXCR4, you go from 47% down to 9%, and it takes longer to get to that major response. In the patients that had no MYD88 mutation, in fact, there were no major responses. This is important because we're going to come back to talk about this population of patients. Now, what do we learn in this study? Well, we also learned that at 5 years, 54% of the patients still remained without progression of their disease, and 87% were alive, which is actually incredible when you keep in mind that many of these patients had seen many different lines of therapy. And of course, once again, when you look at the mutation status, you see differences in how long the disease was kept on check on ibrutinib. And again, at 5 years, 70% of the patients that only had the MYD88 mutation remained free of their disease progressing. If they had both mutations, the average or median time that the drug kept the disease in check was 42 months, so just shy of 4 years. But you see, if you had no MYD88 mutation, we call these wild type patients, they progressed, much sooner. Now, we also learned with the update some interesting, differences in terms of toxicity. The most important of which was atrial fibrillation. Initially, when we reported this study out, 5% of patients had atrial fibrillation. This is when you see, arrhythmia of the heart. By the time we reported out with the longer follow-up, it was now 13%. But keep in mind that most of these patients continued on ibrutinib with medical management. In fact, 7 out of 8 of the patients that had atrial fibrillation. Now, ibrutinib has also been a very important drug for treating other problems associated with Waldenstrom. I think the big one that I know many of you have been interested in is Bing-Neill syndrome. This is when the disease gets into the brain and the spinal cord. And here ibrutinib really revolutionized the way we treat this particular problem of Waldenstrom, where in the past we used to give high-dose chemotherapy and admit patients to the hospital. Now we just send them home, many times and just slightly higher than the normal ibrutinib that we use. Usually we use 420 milligrams once a day. Here we typically use 560 milligrams a day just to be able to get better, brain penetration. And in fact, this is one patient who, before treatment started, you can see that the patient had by MRI, a solid tumorous process here in the brain. And by PET-CT, you see all this area of the brain lighting up. The yellow indicates, a lot of activity, this on the basis of the Waldenstrom. But just a few months later, just look at how much things had changed for this patient. And in fact, in this study, we were able to actually measure levels of ibrutinib in the cerebral spinal fluid of the brain, and in fact show that you could get appreciable levels of drug. Now, there are other BTK inhibitors. I'm excited to show you this slide because it just shows you how when you start something with the discovery of MYD88, that you can actually take that to the laboratory and find out that it actually turns on a pathway like Bruton's tyrosine kinase, BTK. All of a sudden, you've got now a drug like ibrutinib. It gets approved by the FDA as well as the EMA and many other places around the world. But you now see the excitement that it generates in terms of other drug developers wanting to also test their drug in Waldenstrom's. And as a result, we ended up with all these trials, trials with the drug acalabrutinib, trials with the drug with zanubrutinib, and now also in Japan, tirabrutinib. Now, one thing to keep in mind is that when we talk about a BTK inhibitor, you might think, okay, this drug is specifically going to hit only BTK itself, and it's, and that's all it's going to do. That's not the case. Almost always these drugs tend to be dirty. Now, what does dirty mean? Dirty means that you're actually hitting other targets as well. And sometimes that's good because some of the other targets you might hit actually are important to the ability of the drug to work. Other times, of course, it can cause toxicity. And I just want you to take a look at this slide because I think it's very important. This is the pattern of inhibition for ibrutinib. And what we're measuring here is over several hundred different enzymes or kinases, what ibrutinib actually is hitting. And the more of these red blotches you see, it means that it's hitting more of these targets. And in fact, the bigger the blotch, it means the stronger it's hitting it. And you do see now differences between ibrutinib, acalabrutinib, zanubrutinib, as well as tirabrutinib. There are really these off-target effects that are going to be different. And that's why I think it's important when you look at these drugs in Waldenstrom patients, you really need to do a trial for each one of them because the side effect profile or benefit profile may in fact be very, very different. And this is where I just want to focus today on the ASPEN study because this now has permitted the approval of yet the second drug ever in Waldenstrom's, and of course the second BTK inhibitor, for Waldenstrom's, and that's the drug zanubrutinib. And this just occurred by the FDA. So let me just focus a little bit on this very important trial that enabled the approval of zanubrutinib. This was called the ASPEN trial. And there were actually two cohorts in this trial. There were those patients who had the MYD88 mutation, roughly 201 of them, who were then randomized. They could either get zanubrutinib twice a day, so the dose was 160 milligrams twice a day until their disease progressed, or they could get ibrutinib 420 milligrams once a day until their disease progressed. And there was also this cohort 2 that was reported out separately, which were patients that did not have the MYD88 mutation. And these patients could go on and get zanubrutinib. So what did we learn in this trial? Well, what we learned here is that when you compared with the follow-up, which was about 19 months at the time, when you compared the outcome, you saw, in fact, that the major response rate was about the same between these two drugs, ibrutinib as well as zanubrutinib. And major response means at least 50% reduction in the IgM level. But when you looked at the deeper responses, the VGPRs, very good partial response, which means about a 90% reduction in IgM, which we use as a surrogate for measuring disease activity. You see, in fact, numerically, there were more VGPRs among the patients who got zanubrutinib compared to ibrutinib. This, however, did not reach statistical significance. It is important to highlight here that what exactly a VGPR means in terms of the long-term duration of benefit, for a BTK inhibitor remains still to be defined. On the other hand, it's also fair to say that in some patients, getting the IgM down even lower because they have symptoms because of the IgM is important. So that's why it's important to keep in mind these different definitions and what they could potentially mean. Now, in this study as well, they did next generation sequencing for CXCR4. And I thought this was actually a very interesting learning curve from this study. What it showed us is that whether you were on Zanubrutinib or Ibrutinib, those patients that had the CXCR4 mutation actually had fewer of those VGPRs than did the patients that did not have the CXCR4 mutation, i.e. they were wild type. So you can see the difference here for Zanubrutinib as well as Ibrutinib. And of course, when you compare these kind of numbers, you try to come away with lessons of whether or not a particular drug is better for CXCR4 disease than another one is. And that's why this kind of analysis is very important. Now, what was really the highlight of this trial was the differences in the side effect profile. And one very important side effect that I already talked to you about with the Ibrutinib monotherapy study is atrial fibrillation, when you can get, arrhythmia of the heart. And in the case of Ibrutinib, we did see, atrial fibrillation in about 13% of patients. Here in this trial, it occurred in about 15% of patients. So it's pretty much on money with what we had seen with the Ibrutinib monotherapy study. But for Zanubrutinib, look at this, it's 2%. So a big, difference. There was fewer episodes of diarrhea, also bleeding episodes. But conversely, and this is what we have to always talk about, is trade-offs with these drugs. Conversely, there were more events of neutropenia where the white blood count, went down. There wasn't actually an infection signal because white blood count actually protects you against infection. So it's important to have a good white blood count. But there was not an infection signal when you compared across the two different drugs, including the more severe grade 3 infections. There was, however, more usage of the cytokine GCSF in order to be able to get that white blood count up. So I think when you're thinking about, these two drugs, and most of you I know now are starting to say, well, which one is better for me? There are going to be a number of things we're going to have to consider. We're going to consider, how to give the drug. We're going to consider whether somebody is at higher risk for atrial fibrillation or maybe at higher risk for neutropenia. But by and large, having this kind of safety data, I think, is very important. And also seeing, I think, the relative better safety data with Zanubrutinib across many parameters like atrial fibrillation, diarrhea, as well as bleeding is something for all of us to get excited. When you go away today, I want you to say, we have two great drugs, two great BTK inhibitors. And really the onus is up to us as clinicians and also talking with our patients to be able to understand, which one of these drugs may be better suited for a particular patient. And keep in mind that there are going to be other things we're going to think about too, including if you have a problem like Bing-Neal syndrome. We have now a lot of data with Ibrutinib. We have much less with Zanubrutinib in terms of its ability to penetrate into the brain. So those are going to be the kind of nuances that we're going to be able to, try to better characterize. People who may have, bigger problems associated with the IgM that they're making, may be better suited for Zanubrutinib, where you want to knock down that IgM more. So those are the nuances that I think we ought to all keep in mind as we think and deliberate around these two very important drugs. I do want to share with you, though, I think a very exciting study that was presented at the European Hematology Association meeting just a few months ago. And this was a trial which was meant to see that if somebody had a side effect on either Ibrutinib or Acalabrutinib, could you switch them over to Zanubrutinib, and how would they do? And let me, preface that I was excited about this trial because it included previously treated CLL patients, Waldenstrom patients, mantle cell, as well as marginal zone lymphoma patients. So it's good to actually have data that also impacts, our particular community. And so what did we learn in this trial? Well, I think the good news was that in 75% of cases where there was a side effect that prompted the switchover from Ibrutinib to Zanubrutinib, one did not see recurrence of that particular side effect. I think that's really impressive. And that also includes atrial fibrillation. So, why I think this data is very important is because we all want to be able to now maximize on the use of a BTK inhibitor. So if we have the ability, even if you're on Ibrutinib and you encounter a side effect, it is good to know that one can even do a switchover and be able to continue a patient on a BTK inhibitor. Now, one more, piece of information that I think is important to keep in mind is if you remember the MYD88 wild type patients, again, those are the people that have no MYD88 mutation. And in the case of ibrutinib, we didn't see, major responses. Admittedly, the numbers in that study were very small, but this is what prompted, the study on ASPEN to look at zanubrutinib in this particular subset of patients. And very interestingly, there was a lot of activity here. In fact, half the patients, achieved a major response. 27% achieved a VGPR. I do want to say, though, one very important footnote, that when you're testing for MYD88, sometimes the devil's in the details, that if you have somebody who doesn't have a lot of bone marrow disease and you're testing for MYD88, it's possible that you might have missed the MYD88 mutation. And if you look very carefully at the bone marrow involvement in the patients that participated in this study, some of them had no disease in their bone marrow. So it is quite possible that the MYD88 mutation may have been missed in a few people. But on the other hand, look at the other extreme. This is the range where you had patients among treatment-naive patients, 70% involvement, up to 70% involvement. Relapsed refractory, up to 90% involvement. So there were clearly patients that had a lot of disease where you really would have known what their MYD88 status was. And I think, all in all, when you think about somebody who doesn't have the MYD88 mutation, I think now zanubrutinib can be considered. We typically use either bendamustine or a proteasome inhibitor for this patient population, but it's nice to know that, zanubrutinib now represents an additional option. I just want to talk a little bit about some other drugs as well beyond BTK inhibitors. Dr. Jorge Castillo at our institution has been very much looking at Venetoclax. This is a drug that actually blocks BCL2. BCL2 levels are actually elevated in Waldenström patients. And I'm very excited by these results of this study that show major response activity, even among patients who have seen previously a BTK inhibitor, and even among patients that had the CXCR4 mutation, almost on par with those that did not have the CXCR4 mutation. So, and in fact, now showing that the median duration of benefit or progression-free survival was 30 months in this patient population. So this is going to be another very important drug that'll be added to our armamentarium for Waldenström. And in fact, the excitement that we now have, again, based on work that was done in our laboratory, showing, in fact, you could synergize by combining Venetoclax with ibrutinib in the laboratory, is this very exciting trial that Dr. Castillo is currently running, combining ibrutinib and Venetoclax to treat people with Waldenström's who are newly diagnosed and symptomatic. And in fact, this is an interesting study because the patients will be treated for 2 years and then all drugs stop and patients are going to be observed. So the hope is that by combining these drugs, you can get a better punch and be able to not have to treat the patients indefinitely. Now, just a few weeks ago, this very exciting study was published. This was a study by our group looking at the first time ever trying to drug CXCR4. Why not go after CXCR4 since we see it in up to 40% of patients? And in fact, this trial was supported by the Leukemia and Lymphoma Society and combined Ulocuplumab. It's an antibody, much like Rituxan, that actually binds to CXCR4 and it prevents its target, from being engaged by CXCL12. And this was given with ibrutinib in CXCR4 mutated Waldenström patients that needed treatment. Patients in the study got 4 weeks of Ulocuplumab weekly, and then they went on it twice a month for 5 additional months. And then the Ulocuplumab was stopped, but the ibrutinib was continued on. What did we learn in this trial? A lot. We learned, in fact, that we could get patients who had the CXCR4 mutation into earlier responses, in fact, much earlier than ibrutinib alone. We could even get them into deeper responses. And even more excitingly, we could actually see that their ability to respond to drug was almost where we had seen with people that did not have the CXCR4 mutation. So our 2-year progression-free survival estimation was 90%, which is exactly what we see with people that did not have the CXCR4 mutation. Unfortunately, Ulocuplumab is no longer being developed by BMS, Bristol Myers Squibb, and they're not developing it because they did not see a signal in other diseases, bigger diseases that they were looking to see a signal. But in its place, now is the drug Mavorixafor, which is an oral inhibitor of CXCR4. And this trial is currently going on where we're combining Mavorixafor with ibrutinib in CXCR4 mutated patients. I did report some of the preliminary safety data at this year's European Hematology Association meeting. Now, in the last couple of slides, I just want to talk about ibrutinib resistance. And I think in the same token, Zanabrutinib, acalabrutinib, tirabrutinib resistance, because all these drugs bind to the same identical target on BTK. And that's a amino acid known as cysteine 481, CYS481. So if you have a mutated CYS481, all these drugs aren't going to bind, just to keep that in mind. And some patients with Waldenstrom, and this is from a study we reported a few years ago in the journal Blood, can actually have multiple BTK CYS481 mutations in their bone marrow, and in fact, show progression of disease. So my good friend and colleague, Dr. Michael Wang at MD Anderson, has actually been doing a study with a new BTK inhibitor called Pirtobrutinib. It's also known as LOXO 305. And he did this big study and included actually Waldenstrom patients. And this BTK inhibitor binds to a different site on BTK, so not at the CYS481 site, cysteine 481. And in fact, you can see here, he showed responses in 60% of patients who had already seen one of those covalent BTK inhibitors that bind to CYS481. So would have seen, ibrutinib or zanubrutinib or acalabrutinib, which is typically the case here in the US. So this is very exciting. And as a result, my colleagues, Dr. Jorge Castillo, along with Dr. Shana Sorosiak in our institution, along with colleagues at other centers, will be conducting this study of Pirtobrutinib, which will be used at the dose of 200 milligrams once a day for patients that have already seen one of those covalent BTK inhibitors and either had to come off because they were either experiencing side effects or their disease progressed. So this is a very, very exciting trial, and again shows us how we can continue the ongoing, potential of targeting BTK in patients with Waldenstrom. In the last two slides, I just want to say I think this is really a great time because we can actually do something that many others in other cancers wish they could do, which is actually use the genomics to come up with very targeted therapy for a particular patient. And so in this sort of schema, you can actually figure out if a patient has the MYD88 or CXCR4 mutation, and then try to make choices that are logical. Like for instance, prioritizing BTK inhibitors for the patient that has only the MYD88 mutation. In the case of patients who might be double mutated, keep in mind that many of these patients tend to be those, particularly the ones that have the nonsense CXCR4 mutation, that have hyperviscosity crisis. They should be plasmapheresed. And then maybe you might want to think about a different, drug because you want to get that IgM down sooner than later. But if there's no rapid response that's necessary, then you can think about a BTK inhibitor, potentially with rituximab, because you see some data out there that shows that you can get people into quicker responses. And this is actually now going to change because of Zanubrutinib's approval. And that's the patient that does not have the MYD88 mutation. And here, typically, we've used bendamustine and a proteasome inhibitor like bortezomib. But now I think Zanubrutinib can also be added here to this armamentarium. So I do think, we have seen, now the ability to extend our ability to use BTK inhibitors because of Zanubrutinib's approval. Now, in patients that have already been treated, you can think about the same algorithm, but now recognize that this, drug, Venetoclax, which is FDA approved, but it's still investigational for Waldenstrom's, may actually be an option for patients that have already seen a BTK inhibitor. And I'm hoping in due time that Pirtobrutinib may also be added to this list of drugs. And so with that in mind, I just wanted to thank the IWMF for giving me the opportunity to give this timely updates, particularly here on the occasion of the approval of Zanubrutinib, our second drug ever for the treatment of Waldenstrom's macroglobulinemia. And so thank you very much. And I want to now go ahead and try to address some questions that have been raised by various patients who are looking for questions now in the setting of Zanubrutinib's approval. And so some of this we've already covered in the data, so I might be actually a lot briefer than perhaps on other questions. So please come along for this Q&A session. So the first question that we were given is Zanubrutinib a more effective treatment than ibrutinib for MYD88 wild types? Okay, so we're talking about MYD88 wild type Waldenstrom patients. And what we do know based on the data, and keep in mind that, overall, the number of patients in many of these studies, is small. And there are also footnotes like, did the patient really have no MYD88 mutation? Because some of those patients actually had very little bone marrow to actually test for the MYD88 mutation. But what we see now, based on the data that's emerged, is that Zanubrutinib does appear to offer a higher response rate, major response rate, than what we've seen with ibrutinib, although these are not head-on studies. So I do think this would be something to consider. Zanubrutinib should be considered for somebody who has no MYD88 mutation. Okay, does Zanubrutinib work better than ibrutinib for those that are CXCR4 mutated? All right, this is actually also a very good question. And again, reading through the next generation sequencing data from the ASPEN study, you in fact see that, numerically higher number of patients who are on Zanubrutinib with CXCR4, got that deeper response, the VGPR. But the word work better is something that I, sometimes, it's important to clarify. Does getting more VGPRs means that, one drug is working better than another drug? And that may or may not be the appropriate surrogate endpoint. Maybe how long you can keep a patient in a remission, and to which we don't have, those answers today. So I do think, it is exciting what we've seen, more VGPRs associated with Zanubrutinib, but I think the word work better in this question needs to certainly, be refined more as more data, particularly around progression-free survival, continues to come in. All right, if someone develops resistance to ibrutinib, can they switch to Zanubrutinib? I think based on the data we just saw from the Shadman study, I think the answer is absolutely yes. So I do think that Zanubrutinib now offers us also the opportunity to consider a switchover, but this is something that again would have to be done, off-label, with keeping in mind that, a physician based on, their determination might be able to make this recommendation for a particular patient. So it's important to keep in mind that, many times, there may be data to back up a decision, but, still this might be something that may have to be considered off-label, and you need to discuss this individually with your doctor. Now, the Zanubrutinib prescribing literature states that it can be taken once daily or twice daily. What do I recommend? Well, the study with ASPEN was twice daily. There is actually some data that was published as part of the phase 2 trial that Dr. Judy Trotman published in the journal Blood, showing in fact that once daily administration could be performed with very high response rates and even actually a good safety signal. But I would recommend, sticking to what we learned from ASPEN, which was the larger trial. This is the trial that was used for approval, where twice daily Zanubrutinib was administered. I do think this is actually a very important question, and I would really like to see a trial, a dedicated one, looking at once daily dosing in Waldenstrom's, because I think we can learn a lot from this, because convenience of administration is something that I know many of our patients are very, very interested in. All right, can Zanubrutinib be used to treat Bing-Neill syndrome? Well, earlier I talked to you about ibrutinib being used in this setting. There's very limited data on the use of Zanubrutinib in the treatment of Bing-Neill syndrome. Okay, I am currently taking ibrutinib. Now that Zanubrutinib is FDA approved, should I consider switching to Zanubrutinib? I got to say that if somebody is responding, if you're tolerating ibrutinib, this would not be something that I would consider appropriate at this time. And the reason for this, has to do with the fact that, there are going to be trade-offs in toxicity. And as long as a patient actually is on ibrutinib and tolerating it well and responding, I don't think this would be an appropriate switchover because you might be introducing, a different side effect profile. And so I don't think this is wise based on what we know today. Okay, are the Zanubrutinib holding times similar to Ibrutinib holding times for procedures like a colonoscopy, tooth extraction, etc.? I think, in this regard, depending on the procedure, a hold, may be longer or shorter. I think you need to discuss this, particularly with your physician. The recommendations are roughly going to parallel between these two drugs in terms of holding times. But again, the extent of hold will depend on what kind of procedure you're having. So the more morbid it is, the more likely it is to bleed, you can be sure that holding it before and after the procedure becomes more important. But do discuss this because it will differ depending on the procedure with each one of your, with each one of you. Okay, is it known why the occurrence of atrial fibrillation is much less with Zanubrutinib? Well, there have been some very limited data that we know of looking at off-target effects of these drugs and thinking about, what I showed you earlier, that kinome profile where you saw, the activity of Ibrutinib or Zanubrutinib or Acalabrutinib or Tirabrutinib affecting all these different enzymes or kinases. And I think there you get a good understanding of how the differences in which one of these kinases you're hitting off target can make potentially contribute to why a drug either has or doesn't have as much of that particular toxicity. Are targeted therapies eventually going to replace chemotherapies? I think this is all of our wishes, that we're going to be able to get at the Achilles heel of Waldenstrom. And I do think, having understood the MYD88 mutation, translating it, understanding BTK being a very important part of the signaling of the mutated MYD88 molecule, that's our desire. Instead of, using a shotgun approach to this disease, that we're going to go after that particular Achilles heel. And I do believe that we're going to get there through these kind of targeted therapies. But I also want you to think about the slide I showed you in the beginning, how MYD88 is a big octopus. It's got its fingers on a lot of different pathways, a lot of different circuits that it's turning on to keep the cell alive. And when you use a BTK inhibitor, it's only going to tackle one part of it. It's a very important part if you think about it, given the success with BTK inhibitors. But I do think the kind of combinations, as well as other drug strategies to drug perhaps more upstream, closer to MYD88, like HCK inhibitors. In fact, the IWMF has sponsored work to develop an HCK inhibitor. It also got published in the journal Blood. It's known as KIN 8194. But I do think that drugs like that, may in the future get us even closer to being able to shut down completely MYD88 signaling. Okay, is Zanubrutinib recommended for first-line treatment? It is approved based on the data from ASPEN, which included both frontline patients as well as relapsed refractory, and the NCCN, which is a guidelines committee that makes recommendations on treatment, has given a category 1, meaning its highest approval, recommendation for first-line use to now include Zanubrutinib. Ibrutinib is already on there. Now Zanubrutinib has also been included. Okay, should I be concerned about the high neutropenia rate from Zanubrutinib? Keep in mind that even though there was more neutropenia with Zanubrutinib in the randomized study with ASPEN, it did not translate into a higher infection signal. I think that's really important to keep in mind. Though more patients who were on Zanubrutinib did need to get shots of the GCSF cytokine to prop up their white blood count. I am particularly interested in the once-a-day dosing of Zanubrutinib, because if you go back and look at the supplement that was generated in the phase 2 study by Dr. Trotman, it appeared that the neutropenia rate was actually lower with once-a-day dosing. And this is where I think, clinicians might be able to look at that data in terms of deciding for a particular patient they may be seeing neutropenia. how to best navigate Zanabrutinib dosing. Of course, you can also consider, coming down on the dose if you encounter neutropenia with Zanabrutinib. But again, this is on a patient-to-patient decision basis. And also to keep in mind that if you do see too much neutropenia with Zanabrutinib, there is also the possibility of switching over to ibrutinib. Our data for that at this point in time is non-existent. So I do think other studies perhaps in the future might give us a better sense of how we work, to use these two very exciting new drugs in being able to support patients should they, encounter a particular toxicity. Okay, do people with CXCR4 mutations also have a delayed treatment response like ibrutinib? Well, we don't have that data, unfortunately. We don't know the impact of the CXCR4 mutation in terms of the kinetics of response with Zanabrutinib. But with ibrutinib, we do know that when you treat somebody who has a CXCR4 mutation, sometimes you can see a delay as much as 3 to 5 months. And so this is why going after CXCR4 becomes important. Okay, will people taking Zanabrutinib eventually develop resistance to the drug? We don't know that. We do know that the likelihood of that with ibrutinib is much higher with people that have the CXCR4 mutation, but that data still doesn't exist with Zanabrutinib. And I think this is why this is one trial, Aspen, where the long-term follow-up is going to become so important to us. We're going to learn a lot, with the long-term follow-up. Okay, is it known if stopping Zanabrutinib will possibly result in withdrawal symptoms? Again, we don't know this. We do know that Jorge Castillo published a very nice study, in fact, talking about withdrawal symptoms in patients where ibrutinib was stopped. This is kind of odd because the patients didn't have withdrawal symptoms. They didn't have the fevers or chills or sweats and just feeling crummy before they started ibrutinib. But when they stopped ibrutinib, that's what they felt, those withdrawal symptoms. It's not known really if this is also the case with Zanabrutinib. And again, this will be a very important question going forward. It's exciting we have now, this drug, and now we just have to learn a lot about it. It's the same thing we did with ibrutinib. It's the same thing we did with rituximab way back. We got a good, very effective drug, safe drug, but now, there's going to be the opportunity to learn more. Okay, does Zanabrutinib have any effect on WM-caused peripheral neuropathy? I think what the questioner may be asking here is, in terms of specific benefit in somebody who has peripheral neuropathy because of Waldenstrom. Keep in mind there are different mechanisms for peripheral neuropathy associated with Waldenstrom. The one mediated by IgM, which we call demyelinating neuropathy, where the IgM binds to the nerve, to the myelin sheet around the nerve and strips it away. We do know that ibrutinib benefits those patients, but we don't have that data with Zanabrutinib at this time. Okay, why is the dose of Zanabrutinib 4 capsules rather than just 1 or 2 capsules? Keep in mind, this is how we also started with ibrutinib, where initially patients were getting, 3 capsules a day. And then because of reformulation, it was reformulated down to 1 capsule, which of course was more convenient for patients. This may occur, with Zanabrutinib in due time, but that's the reason why. Okay, is there a dose reduction protocol in case of any adverse reactions like there is for ibrutinib? Yes, there is. And again, your particular physician can determine the extent of dose reduction and also the timing. And with that, I guess we've answered most of the questions that were posed to us today. I want to take once again the opportunity to thank the IWMF for giving me the opportunity to talk about Zanabrutinib's approval in this timely updates in the treatment of Waldenstrom's macroglobulinemia.